We're
I
on
hope
recording.
everyone had an opportunity to review all of the very helpful information that Dr. K posted on Blackboard. As a reminder, let me go ahead and share my screen real quick, just so you all are familiar where all the resources are located for the class. Let's see. And hopefully you all can see my screen. So let's see, we are spring. So everyone should have been able to access the syllabus and schedule under the Start Here section. You all can see my screen, correct?
Yes.
Okay, great. So um, schedule, syllabus located there. There's also, where is it? I think it's here that you click
Yes.
course knowledge check, just confirming that you reviewed this section of the course. And then, as you can see here, the breakout of all of the individual modules that we'll be covering this semester. So for this one, if you clicked on module 1, you get an introduction on the content, what the learning outcomes are, and then you'll also be able to access a blank study guide. Um, the the things that some of our very successful students in previous semesters have done is they print off the study guide as they're doing their chapter readings and kind of skimming over the content. They're filling out the study guide, with those quick pieces of information that they come across that the study guide is looking for. Highlight or make an asterisk next to something that maybe they've got a question on or don't come across in the chapter or the text book, and bring that to lecture to ask. We understand that it's challenging and not always possible for you to attend these lectures. They are recorded, so you can refer back to them at your convenience. We highly recommend that even if you are able to attend the live session, that you still go back and re-listen to the recorded lecture. Think of how you memorize lyrics to songs. It's because you're exposed to it repeatedly. And so if you kind of apply that same approach, hopefully it'll help to have a better understanding of the content that we cover and the information. Um, but yes, that's kind of the approach and some of the techniques that previous semesters have put into place and that we recommend that you consider this semester to help be successful. If you can't attend the live session, then again, the recording is there. You can also reach out to Dr. K and I via email. If there's an emergency of some sort, absolutely feel free to call or text us. Please let us know your name and the course that you're in. But, if there's something that obviously cannot wait for a response within 24 to 48 hours, um, you know, we understand that even though you're in nursing school, life doesn't stop. So there's always going to be the possibility for something that's out of everyone's control to happen. And so please feel free to call us if you need to. But questions regarding the content or the course itself, we try to be as timely with our responses as possible. So those can typically be done via email. Any questions with some of those basic pieces before we jump into lecture this evening?
A couple of things, Professor Padilla, I'd like to mention is
Sure.
I know that Professor Padilla just mentioned that life happens. It does. And sometimes there's just no way around the will of God. Certainly, we pray that the grace of God covers the will of God. But in those cases, especially the, around or close to an exam, if something happens, any quirky things with ExamSoft, um, and I know that I think you will be going to campus this semester. Is that true? Does anybody know that? Has anybody heard that? Yes. I know I haven't gotten a schedule yet. On your schedule, it has the weeks outlined, but I don't know exactly the days. So that's kind of still up in the air. And I know that there's hesitancy, based on the next Greek alphabet variant, which is what, Omicron. So I know there's been some hesitancy surrounding it. I don't. It's it's been expected that it will not disrupt this semester, but who knows? So, but if anything happens, and you're on your way to the facility, to the campus, please reach out. Certainly, you guys are in the campus right now, correct? On campus at Echelon Building. So I guess you would have already met or been introduced to your exam proctors. This is the first semester that I've had this course, that Professor Selena and I have had this course where the exams haven't been given online. So please, if there's something happening, obviously get your proctor a call. They're usually pretty available. At least when I was on campus there, they were. But please, reach out to somebody. There's a lot of grace that goes with letting somebody know what's going on, than to wait at the end of the semester when it's definitely too late. So please do that. Please reach out early and as soon as possible. There are different things that we sometimes can help you with that does require us to have the opportunity to help you with early intervention if possible. It's still online via our own computer, but in a room at Echelon. Okay, well, that's good. That's good. That's really good. So then that's actually, we have not met our proctors. Okay, all righty. Well, that's a little bit more uh, better for, say, Professor Padilla and I, if we need to help you get back into your exam or something. So, anywho, and you will still get, from what I understand, you'll still get your exam codes from us. But if that changes, we'll let you know as well. Because this is kind of obviously a process, it's a fluid process. So we'll let you know as soon as we learn anything. And as soon as I'm sent the exam schedule, or Professor Padilla and I are sent the exam schedule, we'll pass it on to you as well. And one more thing before Professor Padilla, ready, steady, go. Pharm 2 is actually a whole lot of bit different than Pharm 1. Pharm 1 is just basically knowledge and information basics, but Pharm 2 is a lot of application, and it's quite a bit different than Pharm 1. The Pharm 2 first exam is usually a little more difficult, so I recommend, if there's things you don't understand on these study guides, they're for reference. And if you don't understand, either reach out to one of us or certainly refer to your book. The Picmonics and everything in the modules are over the top beneficial. So please, 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 especially this first exam, please pay special attention to the study guides. And the information in the study guides are definitely on spot. And if there's something you don't understand, please get into the weeds with your book or study partners, but definitely reach out. Don't let information get away from you and wait till the test and not understand pivotal content. All righty. Sorry about that. I'm done. Amen.
No, that's great. Yes, we do provide blueprints before the exams. I don't know if you need a membership to Picmonic. If you click on them, it should take you right into it. Let's double check.
Mm-hmm. And we do exam reviews as well.
Let's see here. Share my screen again. So I think you just kind of sign up, but I don't think you actually have to pay for a subscription that I'm aware of. But if you encounter any issues, let us know. All
But they're
right.
really good. All the Picmonics in
We
the
are.
modules are really good.
Was there another question? No? Okay. And then also in addition to obviously the recorded lectures, attending live lectures, reaching out to your assigned instructor, your peers, there's also obviously tutors and success coaches that we always like to remind everyone of. We'll obviously be posting more announcements as the semester goes on, leading up to exam 1. We also want to just remind everyone of the need to meet with your instructor in the event that you score less than 75 on any of the exams. It's a nice opportunity just to kind of go through barriers or challenges that you experienced preparing. We can try to help, offer recommendations for things to consider changing in preparation for the next exams, and then of course connecting you with some available resources. But even if you score above 75, know that the tutors and success coaches are available to everyone. They're great resources for consideration. Okay, so no, I've only seen options to pay for it. Okay, yeah, just I didn't have to enter any payment information when I signed up, so I think it's just creating an account. I think we only get access to the ones you provide links for. Okay, yeah, I'm not sure if you have access to anything outside of it, but okay. So we are already almost 15 minutes past the hour, so we'll go ahead and get started. So if you navigate to where I mentioned that the blank study guide is, if you haven't already, access that. You can take notes, but we'll just kind of jump right in and go through some of the content. Hopefully you all had an opportunity to at least skim some of the chapter content. I think for modules 1 and 2, most of the information is very basic, and it's found, I think, in the appendix of the text. So if you have trouble finding the information, you can refer not only to the appendix, but a drug book, because it, again, is very general information. So mag sulfate is one of the first items that we'll be discussing. So who can tell me a little bit about mag sulfate, magnesium sulfate? What are some of the important functions of magnesium?
Let's see. We have muscle relaxant. Oh, are you on? You can read. I apologize. I said,
Oh, no, you're
go
fine.
ahead.
I appreciate you reading the chat because I don't have that up. So
Okay.
if you want to
Muscle
provide with
relaxant,
that, that would be great.
anticonvulsant, calcium gluconate for OD, treats preeclampsia. Absolutely, really good. Laxative,
Awesome.
yes, it can be a laxative. Stop premature labor, preterm
Mhm.
rather, yes.
What are
Cardio,
some of the symptoms of deficiency? If you have low magnesium, what types of symptoms do you think we'd be assessing for, or patients would report?
crickets. Fatigue, muscle cramps, irritability,
Good,
cramping. Bingo.
good.
Decrease
Okay, so
urine
mag
output.
sulfate injection is a naturally occurring mineral used to control low blood levels of magnesium. Magnesium sulfate injection is also used for pediatric acute nephritis and to prevent seizures in severe preeclampsia, eclampsia, or toxemia of pregnancy. It's one of the most important electrolytes to keep replenished, since being magnesium deficient can cause insomnia, anxiety, muscle cramping, constipation, and other problems. So again, muscle twitching, cramps, you might even see mental disorders, osteoporosis. Someone mentioned fatigue, muscle
Yes.
weakness, high blood pressure, irregular heartbeat. Those are some of the symptoms you may see with a patient that has low magnesium levels. Magnesium's a cofactor in hundreds of metabolic reactions in the body. It's required for cellular energy metabolism, functioning of the sodium potassium adenosine triphosphatase or ATPase pump, membrane stabilization, nerve conduction, and ion transport. Okay, calcium gluconate. I think did I hear someone mention calcium gluconate, or
Yes,
maybe yes. Okay,
earlier.
okay. So with calcium, what can you all tell us about calcium?
Yeah, it's antidote, calcium gluconate, antidote for magnesium toxicity.
Okay, good.
What does calcium
What is
prevent?
calcium important for? What is it an important mineral for?
Bones, absolutely. Good.
Good. Teeth, bones, right?
Heart,
Good. Mm-hmm.
muscle contractions,
Yep. Anything else?
blood clotting.
Okay. So calcium, as we mentioned, is an important mineral for the human body. It helps to maintain healthy teeth and bones. A proper level of calcium in the body over a lifetime can help prevent osteoporosis. Calcium gluconate is a mineral supplement and medication that's used by injection into a vein to treat low blood calcium, high blood potassium, and magnesium toxicity. So, good job for whoever mentioned that. Supplementation is generally only required when there's not enough calcium in the diet. Calcium gluconate should be used as a first line agent in patients with EKG changes or severe hyperkalemia to protect cardiomyocytes. Insulin and glucose combination is the fastest acting drug that shifts potassium into the cells. So good information there and good participation. Thank you all. It makes a whole difference when we've got engaged classes. Potassium chloride is our next one. So what do you all recall about potassium?
What did we talk about in Pharm 1? Absolutely. What does it do? 3.5 to 5. There you go.
Good, good,
Slow infusion rate.
good. We never want to push potassium.
Excites the cells within the body. Nerves and heart. Cardiac arrest. Absolutely. Will stop your heart.
Good.
Has been known to.
Mm-hmm.
On death row, it will do that.
Okay, good. So potassium is one of the body's electrolytes, which are minerals that carry an electric charge when dissolved in body fluids such as blood. Most of the body's potassium is located inside the cell. Potassium is necessary for the normal function of cells, nerves, and muscles. Potassium chloride is used to prevent or treat low blood levels of potassium, which is also known as hypokalemia. Potassium levels can be low as a result of disease or from taking certain medications or after prolonged illness with diarrhea or vomiting. Potassium chloride is the most common type used to treat deficiency. The recommended daily intake for potassium is 4,700 milligrams. Most supplements come in 90 to 99 milligram doses. Higher dose pills are available, but usually contain smaller active amounts. So I think some of the key pieces with that, again, are some of the ones you all have mentioned. Definitely knowing the normal range, because if you've got a patient who comes back with a potassium of 6, what would we be concerned for or about?
That's really high. Yeah. EKG changes. There you go.
Perfect. Yes. Right. So we want to definitely get on the phone and report that elevated potassium level to the provider, monitor the patient. So starting off with the basic ranges is very important. And then, of course, knowing what side effects, if it's too low or too high with some of these electrolytes, what are we looking for? What can we expect or should we observe for? Very
Yeah.
good.
Somebody said peaked T waves,
Yeah,
or they said
good.
high, but they're called peaked T's.
All right, moving on to sodium bicarb. So sodium bicarb is an antacid that's used to relieve heartburn, acid indigestion. It may also be prescribed to make your blood or urine less acidic in certain situations. 8.5 or 8.4% sodium bicarb has about the same osmolarity as 6% sodium chloride, making it about twice as powerful as 3% of sodium chloride. For severe symptomatic hyponatremia, where you might see seizures or coma, initial treatment with 8.4% sodium bicarb is reasonable. Insulin. What do you all recall about insulin?
A lot.
What's one of the first things that comes to mind when you hear insulin? What is it used
Lowers the
for? What part of the
diabetes,
body produces it?
blood sugar, pancreas,
Good.
pancreas.
Okay. Too much insulin is what? Deadly, right? It could be fatal if we give too much insulin to our patients. If patients don't take it the way it's supposed to be taken, that could be a huge safety concern. What are some of the symptoms you might see with patients who are having hyperglycemia? If they have high glucose, what might you be assessing or seeing?
3 Ps: polyuria, polyphagia, confusion,
Good.
polydipsia, dizziness, fainting.
What about low? What if we drop their sugar levels too much? Hypoglycemia.
Clammy, confusion, lack of consciousness.
Good. Okay, so insulin, it helps control blood glucose levels, right, by signaling the liver and muscle fat cells to take in glucose from the blood. Insulin therefore helps to take in glucose to be used for energy. If a body has sufficient energy, insulin signals the liver to take up glucose and store it as glycogen. K-exalate or sodium polystyrene is used to treat hyperkalemia, so a high potassium level. Sodium K-exalate is in a class of medications called potassium removing agents, and it works by removing excess potassium from the body. It's typically excreted in the bowel movements, so that's how we would monitor for efficacy. If once after the patient's been given K-exalate, you should see an increased amount of bowel movements. So reassure the patient that it's going to be normal for them to have an increased amount of bowel movements, and that's how that's an indication that it's working, in addition to monitoring their lab levels and seeing that potassium level decrease. All right. So on the study guide, was there a question?
It says, what side effects of this drug should we need to know? Sabine, are you talking about potassium or K-exalate rather? Well, K-exalate, and I think we discussed this in Pharm 1 as well, but K-exalate, what it does is it absorbs the excess potassium through the gut. And so certainly it can cause diarrhea, which is an expected side effect. Certainly constipation wouldn't be one you would expect unless, of course, somebody's severely dehydrated and or they have an obstruction. So those are a couple of things that you watch out for as well, because what it does is it in order to absorb the extra potassium in your gut, it has to use fluid reserves. So if somebody is on Lasix, and they're peeing out their extra blood volume along with the sodium, and you're trying to rid the potassium as well, certainly you could expect heart um, issues, because you will get rid of a certain amount of potassium in the urine, but and if you deplete all of your sodium, and then you're too dry to excrete the potassium, then you certainly can continue to expect heart issues as well. Does that make sense? Which um, which electrolytes are affected by hyperglycemia? Um, Sometimes, sometimes potassium, when you have a shift from the glucose in into the serum, into the cells, um, and also that's one thing you need to worry about is the potassium, because what happens is you force the glucose back in. If you give it with insulin, you force the glucose, as in DKA, you force it back into the cells, and sometimes you can drop the potassium. Does that make sense?
Okay, good questions. Moving on to some of the other questions in the study guide. I think the first one is, what's the max infusion rate for potassium chloride? So typically, someone already mentioned, we never want to push potassium chloride, so we know that offhand, right? It's never going to be a push. If urgent treatment is indicated, so someone with a very low potassium level, maybe less than 2%, I'm sorry, a level of 2 or lower, and maybe they also have some EKG changes or even paralysis, potassium chloride could be infused at a rate of 20 MEQs per hour. As much as 400 MEQs may be administered in a 24-hour period, but we'd want to also make sure that we're monitoring the potassium levels. Potassium is, again, a major cation of intracellular fluid and is essential for the conduction of nerve impulses in heart, brain, and skeletal muscle, contraction of cardiac, skeletal, and smooth muscles, as we mentioned, maintenance of normal renal function, acid-base balance, carbohydrate metabolism, and gastric secretion. So very important to maintain those levels. Why must the IV site be monitored when IV potassium chloride is infusing? Why do you guys think we need to be observing that IV access site?
May burn,
Mm-hmm.
irritation, phlebitis, infiltration, necrosis.
Good. Yeah, so it's a vesicant, right? Potassium chloride, IV potassium chloride is a vesicant. A vesicant is defined as a drug that is capable of causing tissue injury. Examples of common vesicant medications and fluid include vancomycin, which is one of the antibiotics, potassium chloride, calcium gluconate, dopamine, dilantin, a lot of the anti-neoplastic drugs, dextrose that's greater than 10%, and 0.45% sodium chloride are also examples. So definitely want to make sure that we're monitoring those IV sites whenever those types of medications are being administered. What is done if infiltration of the IV potassium chloride is suspected? So you guys already mentioned some of the signs and symptoms, right? Infiltration, burning, irritation.
We have
So if
stop
we see that,
immediately.
good. Yes. So we want to stop it immediately before it causes further damage. So before we even start the infusion, we're educating the patient. If you start to experience these types of symptoms, please notify us immediately, right? Should EKG monitoring be done when IV potassium chloride is infusing? What do you all think?
Yes.
Good. So EKG changes have a sequential progression, which roughly correlate with the potassium level. Early changes of hyperkalemia include tall peak T waves, which was mentioned earlier, with a narrow base. It's best seen in precordial leads, shortened QT interval, and ST segment depression. What are adverse effects of potassium chloride administration? So we talked about the local effects that we might see, right? The infiltration, burning. But what else can you all think of?
Chest pain, sloughing of tissue.
Okay. So we're adding potassium. So if we get that potassium level too high, what do you all think we might see? Definitely cardiac related types of symptoms.
Trouble breathing.
Trouble breathing. Yep. Good. And so if the potassium does get too high, what are we going to give them to bring it back down? What did we talk about a little while ago?
Calcium gluconate.
Which one makes you poop?
K-oxalate.
Yes, K-oxalate, right? All right. What client education is important for the client taking potassium chloride?
Do not crush or chew. Take with food. 8 ounce and water.
Okay. To administer with plenty of fluid to decrease stomach irritation and discomfort. We also want to tell them about some of the dietary sources for potassium. So leafy green vegetables, tomatoes, cucumbers, zucchini, a lot of those fresh fruits and vegetables, root vegetables like carrots, radishes, beans, peas, right? How is the effectiveness of IV potassium monitored?
EKG.
Okay.
Blood tests, serum levels. Yeah, certain
Good.
electrolytes. Yeah, very good.
Who's at risk for hypokalemia? So low potassium.
Bulimics, absolutely, good job. Dialysis, Lasix,
Good. Good.
diuretics, of course.
Patients that are having a lot of vomiting and diarrhea too, right?
Alcoholics, bingo. We'll talk a lot about
Good.
alcoholics this semester. Addison's disease.
Good. What about hyperkalemia?
Diabetics.
Okay.
Good. CHFers, renal failure,
Good. Yes.
ACE inhibitors, or
And then just
potassium
depending
sparing
on what types of
diuretics.
medications, right? Some of our medications that patients take impact electrolyte balances. So angiotensin converting enzymes, which you all are going to be learning about within the next couple of weeks. So ACE
Right, ACE
inhibitors,
inhibitors.
angiotensin receptor blockers, ARBs, potassium sparing diuretics, which I think someone mentioned. Salt substitutes are high in potassium also, so we want to make sure that we educate patients about that. If they're needing to monitor their potassium, make sure they're not using salt substitutes. What about, okay, we already talked about medications. How is hyperkalemia managed? Well, we talked about K-oxalate already. They might be given calcium gluconate also, which we discussed. Acutely lower potassium by giving IV insulin with glucose, a beta 2 agonist by nebulizer, or both sometimes. So it just kind of depends on how high the potassium level is. We talked about K-exolate. Someone asked about adverse effects of K-exolate. So as Dr. K mentioned, loss of appetite, upset stomach, nausea, vomiting, constipation, or diarrhea. Again, bowel movements are expected, but if it's severe enough, they're going to be at risk for getting dehydrated and possibly experiencing some of those additional symptoms. So we just want to monitor that. How does insulin work to lower potassium? I think we talked about this also. Dr. K mentioned the shifting of potassium into the cells with insulin by stimulating the activity of the sodium hydrogen antiporter on cell membrane, promoting the entry of sodium into the cells, which leads to activation of the sodium potassium ATPase, causing an electrogenic influx of potassium. IV insulin leads to a dose-dependent decline in serum potassium levels. What should be given with insulin to prevent adverse effects?
Carbs, food,
Good.
glucose.
You guys will usually see that in the clinical settings, right? Usually they'll say, the morning dose of insulin with tray, with snack. You'll see that a lot of times written as the protocol or order, depending on the facility you're at. What are the therapeutic uses for magnesium sulfate? We've talked about that also. So treating preeclampsia or eclampsia in our pregnant patients. Excuse me. Severe asthma exacerbations, constipation, barium poisoning, or some of the others. Common adverse effects of mag sulfate. We talked about that as well. So too much mag sulfate, if we're trying to minimize contractility of the muscles or muscle activity, what is the severe version or outcome of that we'll see?
There's a question about insulin and potassium.
Oh, okay.
Question about Emma, you have a question about insulin and potassium?
Yes, thank you. I was just wondering, so the insulin causes the potassium to go back into the cells from the blood, and that's because like if you're using the sodium potassium pump, right? That's the pump that it's affecting, correct?
Well, mainly because it increases the permeability of cells to potassium.
Okay.
That's one thing. It does have to do with the cell membranes. It promotes, particularly in the skeletal muscles, by increasing the sodium potassium, by triggering the sodium potassium pump.
Okay, perfect. That's all I wanted to know. Thank you.
You're welcome. And the other question, Professor Padilla, we had a couple of people answer with paralysis, flaccid paralysis.
Good. So respiratory paralysis for sure. So if you are giving mag sulfate, you're monitoring respiratory status for sure. Circulatory collapse might be something else you see. Low core body temperature or hypothermia, pulmonary edema, depressed or poor reflexes is the other big one that we're assessing. Low blood pressure or hypotension, flushing, and drowsiness are also common ones. So definitely want to make sure that you have those studied. What are life-threatening adverse effects of IV mag sulfate? So absent DTRs or deep tendon reflexes, respirations that are less than 12 per minute, chest pain, decreased urinary output, so less than 30 mLs per hour, and of course, significant drops in pulse or blood pressure. Meds, when administered with mag sulfate, that can increase the risk of respiratory depression. Anything that impacts morphine, those types of medications. So we'd be assessing again for loss of DTRs. Are there questions coming through?
Yeah.
Sorry, I can't.
Somebody said for the common side effect of magnesium sulfate, can prolonged bleeding time be one?
I don't know. It may be. I think the ones that we more commonly monitor for are those having to do with, again, muscle-related types of responses. But let's see. What you're asking? Increased bleeding time, prolonged bleeding time with mag sulfate?
Are you talking about like if somebody's on, say like in Pharm
A
1, we
blood
talked
thinner?
about Coumadin a lot. So Coumadin prolongs bleeding time. If that's what you're talking about, magnesium does have, it can slow down the bleeding time, but it's especially the thing I think you would particularly look out for it if your patient's on mag sulfate, at the later stages of pregnancy and or delivery, because in that case it can prolong the bleeding time, and maybe in OB, that may be an issue. I'm not sure if that's what you mean.
Okay, good questions. Almost through here, and then we still have module 2 to get to. So for the remaining questions, I'm trying to think if this is stuff that we've already covered. How many do we have? We're on page 4, right? Still. Where are we? I lost my place. Who should not take? I think that's the next one. What are contraindications to the administration of mag sulfate? So who shouldn't take mag sulfate, or who is it contraindicated in? So if we already have a high amount of magnesium, obviously if the level's high, low amount of calcium, patients with myasthenia gravis, those with skeletal muscle disorders, progressive muscle weakness or carcinoma, decreased kidney function, or severe renal impairment.
Yeah.
The effectiveness of magnesium sulfate is determined, improvement of symptoms that it's being treated, the patient's being treated for, right? So decreased contractions in labor, preterm labor or preeclampsia, eclampsia, resolution of seizures, if that's what the patients are getting treated for. But of course, we also want to monitor lab levels. Antidote for hypermagnesemia. So if the level's too high, what are we going to give them? You all know? I think someone mentioned it earlier.
Yep. Calcium chloride. There you go.
Good. Or gluconate represent the antidotes. How is bicarb used to manage acid-base imbalances? So it's a buffer, right?
Right.
If you guys recall. So when bicarb ions combine with free hydrogen ions and become carbonic acid, hydrogen ions are removed, moderating pH changes. Bicarb can be administered by IV. In cardiac arrest, a rapid IV dose is given, but usually injection or IV. Adverse effects of bicarb. aggravated CHF or congestive heart failure, cerebral hemorrhage, swelling, high blood sodium levels, low blood calcium levels, low blood potassium levels, muscle spasms, and metabolic alkalosis. And to monitor effectiveness of bicarb, well, it would be an improvement of those, whatever it's being administered for, right? So if the patient is in acidosis, you want to see an improvement or change in those ABGs. If they're taking it for, I think we talked about some of the other indications, heartburn, right? Relief of those symptoms, whatever symptoms it's being administered for. And then, of course, also monitoring lab values. All right, so that's Module 1 study guide. And we can jump over to Module 2. Did you want me to pull that one up and go through that as well, Dr. K? Or did you have
Do you
it
mind?
up?
No, I don't
No,
have
sure.
it up. I apologize. I got up to my apartment and it's like, oh my gosh, all my stuff is in my car.
No, absolutely. I have it
Sorry,
up
guys.
and ready. All
Big
right,
not
jumping.
prepared on my sign on my head.
No, you're absolutely fine. I had it up. Just wanted to confirm with you. All right, Module 2. So jumping into this one, adrenergic agents, antihistamines, corticosteroids. So adrenergic agents act either by enhancing or reducing the activity of the various components of the sympathetic divisions of ANS, sympathomimetic or adrenergic stimulants, with adrenergic agonists. Those are drugs that lead to stimulation of the adrenergic receptors. In doing so, adrenergic agonists stimulate activation of certain aspects of the sympathetic nervous system and are thus known as sympathomimetics. Try saying that fast 5 times at the end of a long day.
Indeed.
Dopamine. All right. Do you all recall dopamine? What do you think of when you hear dopamine?
What does dopamine do to your heart?
Where's it made?
It does improve blood pressure. Correct. It corrects.
Good.
That's absolutely true. But what is a dopamine known as? What is dopamine also known as? Happy.
Good.
Yep.
It's made in your brain, right? It's a neurotransmitter. It acts as a chemical messenger between neurons, and it's released when your brain is expecting a reward. When you come to associate a certain activity with pleasure, mere anticipation may be enough to raise dopamine levels. So the natural version of dopamine is adrenaline, noradrenaline, dopamine. Those are all those natural catecholamines. Synthetic versions would be dobutamine, isoprenaline, ephedrine, amphetamines, phenylephrine. So those are just some of the examples. The next one's dobutamine. Let me scroll down here. Dobutamine is a medication used in the treatment of cardiogenic shock and severe heart failure. It may also be used in certain types of cardiac stress tests. It's given by injection into a vein or intraosseous as a continuous infusion. And dobutamine is also known as Dobutrex, and it's a positive inotropic agent. Epinephrine. What do you all know about epi?
From last semester. Adrenaline.
Okay, also known as adrenaline.
Helps with
When do we
allergies.
get epi?
Anaphylactic treatment.
Good. So allergies, a lot of folks with food-related allergies have to carry EpiPens. A lot of schools and facilities have them on hand, right?
Mhm.
We have it on hand whenever there's the potential for allergic reaction or anaphylactic reaction to some type of medication. A lot of times with immunizations or vaccines, right?
And it's
So
another comment said it's used in a code.
yep, it's definitely one of those medications that's stocked in a crash cart for sure. So, as we mentioned, also known as adrenaline, it's mainly made in the adrenal medulla, so it acts more like a hormone, although small amounts are made in nerve fibers, where it acts as a neurotransmitter. Epinephrine and norepinephrine are very similar neurotransmitters and hormones. While epi has slightly more of an effect on your heart, norepinephrine has more of an effect on your blood vessels. Both play a role in your body's natural fight or flight response to stress and have important medical uses as well. EpiPens, another use is bee stings. It causes rapid peripheral vasoconstriction, dilates the bronchi, and blocks the effects of histamine. Norepinephrine, we kind of talked about this along with epi. One of the other names for norepinephrine is Levophed. One of the rhymes or kind of ways to remember this is Levophed, leave them dead. That's, I don't know if that gets used anymore, but that's, I think, something that Dr. K and I used or are accustomed to hearing when we were back in school. So because it is a vasoconstrictor, you definitely want to make sure that you're monitoring patients who receive norepinephrine. Dr. K has shared stories of acquaintances that have had side effects from Levophed. It's a naturally occurring chemical in the body that acts as both a stress hormone and neurotransmitter. It's released into the blood as a stress hormone when the brain perceives that a stressful event has occurred. If infusion rate is too high, blood pressure will become elevated. Benadryl or diphenhydramine is in a class of medications known as antihistamines. It works by blocking the action of histamine, which is a substance in the body that causes allergic symptoms. Benadryl or diphenhydramine will not relieve cold symptoms. It's used to relieve symptoms of allergies, hay fever. It can be used in the common cold, but it won't relieve the symptoms. The symptoms also that it helps to treat are also rash, itching, watery eyes, itchy eyes, nose, throat, cough, runny nose, and sneezing. It's also used to prevent and treat nausea, vomiting, and dizziness that can be caused by motion sickness. Zyrtec or cytarabine has similar efficacy and onset of action as compared with Benadryl or diphenhydramine in treating acute food allergic reactions, with added benefits of similar efficacy but longer duration of action compared to Benadryl. Cytarabine is a good treatment option for acute food allergic reactions. Let's see. Allegra or fexofenadine is the least sedating of second generation antihistamines and least likely to have synergistic effects with alcohol. So if a patient has a question on whether or not it's safe to maybe have a glass of wine or a cocktail, this would be the medication that would have the least sedating effect of the antihistamines. Allegra works within a couple of hours and Zyrtec works within 1 hour. Several studies have found Zyrtec to be more effective than Allegra at relieving symptoms of allergic rhinitis and urticaria, and it appears to have a longer duration of action. Claritin, very similar actions. I'm trying to skim because I know we only have a couple of minutes left. Phenergan or promethazine, we use that typically to prevent and treat nausea and vomiting, related to certain conditions. It's also given before or after surgery, can also be used to treat motion sickness, can be used with other medications to treat severe allergic reactions or anaphylaxis and reactions to blood products. Corticosteroids like prednisone, cortisone, dexamethasone, methylprednisolone are synthetic drugs that are used to treat a wide variety of disorders, including asthma, arthritis, skin conditions, and autoimmune diseases. Drugs mimic cortisol, a hormone that's naturally produced by the adrenal glands in healthy people. Major uses of epi we've talked about. So emergency situations, serious allergic reactions like to insect bites, stings, foods, drugs, or other substances. It acts quickly to improve breathing, stimulate the heart, raise blood pressure, reverse hives, reduce swelling of the face, lips, and throat. Mechanism of action of epi. Its action is on alpha-1 receptors. So it induces increased vascular smooth muscle contraction, pupillary dilator muscle contraction, and intestinal sphincter muscle contraction. Other significant effects, as you all recall, fight or flight. So it increases your heart rate, myocardial contractility, and renin release via beta-1 receptors. How is epi administered? Usually injection, right? It might also be a component in some nebulizer treatments. Those are some of the most common ways that it's administered. Adverse reactions to epi. So if it's increasing all of these systematic processes, the fight or flight response, you might see anxiety, apprehensiveness, restlessness, tremors, weakness, dizziness, sweating, palpitations, pallor, nausea, vomiting, headache, and respiratory difficulties. And these side effects can last for about 10 to 20 minutes. How does epi contribute to the development of dysrhythmias? Adrenaline causes an increase in systolic blood pressure, a decrease in diastolic blood pressure, and an increase in heart rate. Circulating adrenaline may increase the frequency of arrhythmias, both directly via changes in the ventricular repolarization and indirectly via adrenaline-induced hypokalemia. What's the mechanism of action of norepinephrine? So it acts on beta-1 adrenergic receptors, causing increase in heart rate and cardiac output. Let's see. Complications are associated, what complications are associated with norepi? So slow heart rate, high blood pressure, irregular heartbeats, confusion, anxiety, shortness of breath, but with or without respiratory difficulty, headache, nausea, and vomiting. Mechanism of action of dopamine. So I think we talked about this being a neurotransmitter, right? Dopamine produces positive chronotropic and inotropic effects on the myocardium, resulting in increased heart rate and cardiac contractility. Complications associated with dopamine, irregular heartbeats, nausea, vomiting, anxiety, headache, chills, goosebumps, shortness of breath. Ooh, we still have a ways to go. I'm trying to think if there's anything else that we haven't talked about. Let's see.
Does anybody have any questions so far?
I had a quick question real quick. When we're going to the study guide, I'm just trying to go through my reading and kind of see where it was applying to it. So I'm lost as to what book we're in specifically, because I was between like Lewis and our Pharm one. So I was just trying to figure out where you were at.
So the assigned chapters, when you look at Module 1, for example, it has the chapters where you can find a majority of the content that's on the study guide. Same thing with Module 2. So for Module 1 in Course Point, right, the Karch book, Appendix A is what's recommended there. You can also look at Chapter 16 in your Med Surg book. Are you all able to see where those assigned chapters are and the listed resources or books?
ATI is matching up for me. The chapter 2 is not on. So do we go to the chapter 1 or page outline? So I don't, Professor Padilla and I don't have access to the ATI material. So as far as ATI and the book, I can't actually speak to that, and I apologize. So if you use I know the ATI information might have changed. So if you'll use the index, that'll help a lot. I think that's what Brianne said, perhaps. But as far as the ATI, you have access, or you will have access, or do you have an ATI access already, don't you? From last semester? Okay, so then all of you, you have access to module 1 through 3, 4 through 4 through 7, 8 through 12. I think I posted that and said something about that in the announcements. So as far as your final, it's going to be an ATI quiz worth 15% of your grade. So those practice ATI questions will help a lot, a whole lot. But I know I didn't answer your question about the ATI book. But to answer that question, I don't know. An hour, Alice, although we're 4 minutes over.
All right. So the remaining questions, you should be able to find the information. A lot of this is repetitive. It's just asking the same information, but in a different way, as you all saw with Module 1. So, we're happy to try to squeeze in any questions that you're not able to complete on the next lecture next week. But you shouldn't have too much trouble finding the information to answer some of the study guide questions. But we can allot, the first few minutes of next week's lecture just to see if you all got stuck anywhere or have questions from this week. And then, of course, course point quizzes are due on Sunday nights. In the event that there's, something that comes up that prevents you from taking that, I believe Dr. K generously extends those deadlines to allow access, but we don't recommend that you not take them, as it obviously helps to complement the content, but you don't want to get behind at all. The last thing you want to do is have 20 quizzes that you have to try to squeeze in between all the other exams. You'll find that as the semester gets going and you have multiple tests on weeks, same days of the week sometimes, it's not going to be the best scenario. So you want to maintain those quizzes as well. I'm trying to think if there's anything else before we wrap up. Was there any other questions that came through, Dr. K?
Well, there was something about somebody's looking for the study guide. So I was going to share my screen and show you where they are. So I'm going to share my screen.
And the lecture's being recorded. So at the beginning of lecture, I navigated to where they are in Blackboard, so you can refer back to that as well.
Here they are. This is module 1. See this right here? It'll say, where did I pass it up? Let's see, wait a minute. Module
and someone
1.
in the chat made a good point. If you
Here it is,
didn't
right here, study guide.
The getting started part, if you didn't go there and complete it, you might not have access to all of the module
There
content.
And
so you'll
Professor
want to go
Padilla
to
showed that
start
to you
here and
earlier.
complete that.
Yeah, there it is. Start here. And then you go to knowledge, course knowledge check. In order to proceed and access the contents of this course, you must complete this one question acknowledge check. Because what it's saying is that you agree to the terms of this course as expressed through the course information, the syllabus, and the schedule. If that makes sense. And that's in your start here part. So it's got the handbook in there. It's got a bunch of valuable information. Okie dokie. Oh, good. Perfect. All righty. Professor Padilla, that was a wonderful lecture. Thank you.
I apologize for going over. I think we kind of allotted time to answer questions at the beginning, but again, the best approach would be to try to have some of those study guides completed before attending lecture, and then of course come with questions. But everyone have a safe rest of your evening. Thank you all for joining and participating.
Yes. God bless. Safe travels. Remain safe during the Omicron variant, and certainly blessings to you, your family, and all. Thank you very much.